I just want to say a couple of words about Natasha Singer, the New York Times reporter who's agreed to moderate this panel, this critical panel about the value of healthcare data outside of healthcare. I think she's the perfect one to do it. She's been writing for 2 years a series in the New York Times called Data for Sale, You for Sale. And so she's been exploring across not just healthcare, but across all industries, what's going on with Americans' personal information. And so, Natasha, I'll let you take it from here and the panel and get out of your way. Thank you.
Thank you, Deborah. And Peter Hustings is a really hard act to follow, but we're going to do our best. My name is Natasha Singer, and I'm a reporter in the business section at the New York Times. And for the last few years, we've been doing this series called You for Sale, where we look at the business of consumer data. And that means data brokers and analytics companies that have collected 1,000 different details, 5,000 different details, 10,000, 50,000 different details on the majority of adults in the United States. And it's a very opaque industry because it's consumer data. It's not health data. It's not credit data. Therefore, they're not obligated to show consumers the data, and they don't have to answer questions from the likes of me. So it's been really interesting to learn about how they work. And some of those companies use the information to score consumers and give them invisible scores and put them in categories that they might not like to be in, like the worried well or the struggling survivor. And after we did some of these stories, Jay Rockefeller's office in the Senate opened an investigation. Ed Markey's office in the House opened an investigation into some of these companies, and the FTC opened an investigation into some of the scoring and other type companies at the end of last year. So I was particularly interested when Deborah Peel asked me to moderate this panel on the value of health data outside of healthcare. And we spent a lot of time as a panel trying to parse what this meant. Outside healthcare was clear to us. Obviously, it meant to us outside of the formal doctor-patient relationship, outside of the formal patient-hospital relationship. But how do we define health data itself? Because it encompasses this huge swath of information. It could include HIPAA-protected data that's been aggregated and so-called anonymized and used, for example, to spot really important trends. It could include consumer search queries that end up as part of Google flu trends. It might include consumer purchases of over-the-counter aspirin or Advil that do end up in some profile. And the potential value of this data is enormous. With all the new sensors and connected devices, we might use big data analytics, for instance, to spot problems in medication adherence among the elderly. Or we can use all kinds of devices personally, right? You can have your own blood pressure monitor, your own heart monitor, your own pedometer, your own calorie counter, your own sleep monitor, your own emotion tracker. And that's what we call the quantified self-movement. And all that has the power to, has the potential to empower consumers to make better lifestyle choices to improve their health. But on the flip side, we have the concerns that with all this exponentially increasing health data out there, it's possible that the companies we patronize and even third-party companies we don't know and have never heard of will use our data to make inferences about our health that we may find intrusive or may be incorrect. And of course, the longer-term concern is whether that's going to lead to some kind of discrimination through algorithmic inference. Some of you may be familiar with the work of my colleague at the Times, Charles Duhigg, who wrote about a program at Target that identified pregnant women through their purchasing patterns, such as prenatal vitamins. And sometimes Target knew that a woman was pregnant even before she had told her family members. And so that raises the question of how our health data is being used outside of the healthcare arena and by whom, and most importantly, should there be limits on that healthcare data collection outside of healthcare, and what should those limits be? And finally, I have another thought about this in the way we describe health data outside of healthcare, because I've been covering consumer data, which is not regulated, But when a person with a disease goes online and does a search query or goes to WebMD or Everyday Health and they're looking up their health condition or they're using a symptom tracker, is that consumer data, or are we now talking about patient data? And should we treat that differently? So those are some of the themes we're going to be tackling this morning. Just one note in terms of structure, I'm going to very briefly introduce the members of our distinguished panel, and then they're each going to talk for a few minutes about their particular work or interest in the health data area. Then I'm going to ask a couple of questions, and then we're going to open it up to you all to ask questions. So our first panelist, David Wiggin, is the Program Director of Healthcare and Life Sciences for Teradata Corporation. And his responsibilities include global industry strategy, marketing, offer development, and field enablement and support. And when I asked him to send me a note that was more informal about what he was interested in, he said that his favorite source of info on healthcare analytics, healthcare social media, and mobile health is Twitter. And he thinks the biggest changes coming in healthcare in the next decade will come from affordable genomic sequencing and wearable biometric devices. So that's David. And then next, we will hear from Michelle DeMooy, who is the Senior Associate in National Priorities at Consumer Action. She advocates for consumers on privacy concerns both in the digital and health arenas. And when I asked her to send me a note, she said that her career as a privacy advocate has led her family to surmise that her real job is to make them feel paranoid. Along with annoying store clerks who are refused her driver's license, getting into fights with the managers at CVS when she refuses to sign off on her prescriptions. She also pays in cash at bookstores and generally embarrasses her 2 children. Then we have Ranieri Guerra, who is a physician who specializes in public health in Italy and the UK. He has practiced in several areas of the world besides Italy. Before moving to Washington, D.C., where he is the scientific attaché at the Embassy of Italy, he was research director at the Italian National Institutes of Health and the director of health at the UN Agency for Palestinian Refugees. And after Ranieri, we will have Cora, who's an attorney at the Federal Trade Commission Division of Privacy and Identity Protection. She investigates and prosecutes violations of federal law protecting privacy and security, and she's going to talk to us about whether there are any protections for health data outside of healthcare. And last, we have Doc Searls, who's the author of The Intention Economy, When Customers Take Charge, and he is a co-author of the Clue Train Manifesto. He's a fellow at the Center for Information Technology and Society at UC Santa Barbara. And one of his big beefs is that all our healthcare data is siloed. And if we could just get them to be integrated, it would empower patients and consumers. And he, when I asked him to say something about himself, said, Doc has been impatient with more than 20 healthcare providers since he arrived on Earth at the peak of the baby boom. His documentation of this consists of a mostly useless pile of paper and CDs that sits in the office of a former doctor in Boston waiting to be picked up. So we will start with David Wiggin.
Well, it is a pleasure to be here, and as Natasha mentioned, my focus at Teradata is healthcare and the healthcare industry. So what I'd first like to do is to start with something that I believe we can all agree on. And this is a construct that came originally from the Institute for Health Improvement, and we heard it become very public with an article that Don Berwick wrote just 5 years ago. And this construct is called the triple aim. And the triple aim is, what is it that we are really trying to do with healthcare? And it involves 3 points. First, deliver better care for individuals. Second, deliver better health to and among the population. And then 3, reduce the per capita cost of healthcare. So better care, better population health, and reducing per capita costs. So given that construct of the reduction of costs, if we now think about the secondary use of health data, so not data in its primary use between a patient, in a doctor, in the doctor's office, but rather the secondary use of those data, what I'd like to do is to is to bring you through just a number of examples of those data being used for very productive purposes, and then move on to the future of data, all within just a few minutes. First of all, population health. We know that there is tremendous regional variation in the quality of care, in utilization, and the cost of care. Why do we know all of that? Because some very smart people at Dartmouth have made it their business to report to us on that. So we know that in the United States we have that situation. Population health is not uniformly taken care of. We have an equity problem in healthcare in the U.S. We know that medical research, that each of the research specialties, secondly, trigger a lot of the advances in what we now call evidence-based medicine and evidence-based guidelines. They do that from the secondary use of data. No one single physician or nurse or practitioner has access to the myriad data that are available here, and yet when those data are studied, we can figure out what works and what doesn't work and build that into evidence-based guidelines. From a provider perspective, we do want our hospitals and our surgery centers and ambulatory centers to be more efficient. How are they going about being more efficient? Well, there's at least a few ways that I'll mention to you that our customers are becoming more efficient. They're thinking about what might be coming in terms of healthcare demand. Should we build this wing? Should we add this facility? Should we expand this based on the fact that they need physical plant to deliver care? They do that with a secondary use of data. Almost more importantly, and very much more in the news today, they are solving system problems today. 30-day readmissions is on the tongues of many of us today. Hospital-acquired infections came before that 5 to 10 years ago. And what is it that hospitals are doing to improve care, to make system changes to care? They're measuring, and then they're making process improvements and measuring again. This is all the secondary use of data, again, all covered by HIPAA. Next, payers of healthcare, that is both public and private. We're about at a 50-50 percentage break here in the United States between public and commercial payment for healthcare. And outcomes analytics is the study of which treatment works better for an individual in this situation, with this diagnosis, with this demographic, et cetera. Maybe even which genome markers. Outcomes analytics is helping us to answer that question so that we can give the right person the right treatment at the right time. We wouldn't have that apart from the secondary use of data. Predictive analytics. So how is it that we can look at a person's early health history and make predictions with some veracity about the future of their condition and what can we do to help them now? So a simple example, if someone is identified by their clinician as pre-diabetic, that clinician will work with his or her patient to help them to avoid going into that disease further. And there are a number of steps that you can take. That's just one example, but can data inform the practice of medicine if we study it broadly? Our customers have found that the answer to that question is yes. The detection of fraud, waste, and abuse. We in this country have estimates between 3 and 10% of our healthcare bill goes to bad guys. Is it possible that with the secondary use of data, we can identify markers for fraud, waste, abuse, overpayment? The answer to that question is absolutely yes, and it makes a great deal of sense to invest there and even get to the point where we don't pay the bill until we're satisfied that we've passed those tests. And the reduction of per capita costs. Payers are especially attentive to this. Large employers, our government, are all trying to squeeze the most value out of healthcare that we can. Sometimes that means helping people who need help in a targeted care management or disease management program. But how do I know who to reach out to if I don't know that the person might have this chronic condition, either developing or not. So all of these use cases have their data foundation in claims data and in clinical data, electronic health record data. Now that is a relatively large data set. Now multiply that data set times not 1,000, but probably 1,000,000. And that's where we're going to be in the next 10 years. With the explosion of whole genome sequence data, as Natasha mentioned, the quantified self movement, those data tracking how many steps I take today, and I can tell you that. If you ask me later, I'll tell you how many steps I've taken. How well we sleep. What is my blood glucose level? Did I take my medications on time? What's the progress of my weight? And these biometric sensor devices are now becoming so high-tech that they will be no more invasive or noticeable on you than a Band-Aid. Some will even be implanted with your other devices to make sure that your pacemaker is on track, and if it needs an adjustment or a tune-up or if it's doing well. We are emerging, we are just on the precipice of a big data revolution where all of these data have the potential to, I think as Natasha said, help us to become healthier, to live the fuller, high-quality lives that we're after, and the secondary use of that data, judiciously protected from a privacy perspective, is a part of that equation.
Thank you, David. And now we'll have Michelle DeMooy.
Hi. I keep picturing a pacemaker zapping me for eating a donut or something. You know, I know that's not what you meant, but for some reason I kept picturing that. So, hi everybody. I'm Michelle DeMooy from Consumer Action. And just to give you a bit of background, Consumer Action is a 42-year-old national nonprofit. We're headquartered out in San Francisco, but have offices in LA and DC. The way we approach consumer education is in direct education materials that are online and offline in 5 languages. We also go directly to community-based organizations to provide training and materials to them. And our DC-based advocacy team focuses on what we call pocketbook issues. So insurance, credit, housing, and now, of course, privacy has become one of those too. We've been involved in it for a long time, but more and more it's a pocketbook issue. I've been working on privacy for the past 5 years, and my career trajectory has actually landed nicely in privacy. I started as a software engineer for .coms, and then moved on to product marketing and advertising for websites, and then into consulting for a lot of nonprofits, and including a lot of women's-focused nonprofits. So it's near and dear to my heart, health privacy in particular. So I want to kind of switch gears a little bit and talk more about the consumer side of the value of health data, and sort of how limited that actually is in our perspective, and then the sort of industry side and how very valuable it is from their perspective. Health data has always been valuable to consumers monetarily and personally, but of course personally maybe more so. It's been recognized as a personal commodity, one that we seek, and we seek to fiercely protect. Accessing and organizing their health data is of course a huge value to consumers. Everything that David talked about, from fitness apps to you know, everything everybody knows, including things that sort of border on medical devices such as blood sugar monitors, or the app that just helps you look at precancerous moles, although apparently that doesn't work very well. And also, it helps people organize information in the sense that they can track their records, track their treatments, and make sure that there are no errors. And that's all great and important. But much of the value, in my opinion, of health data, it sort of stops there for the data donors, right? They aren't the people who are being compensated for this. And the simple truth is that the money and the value that comes from health data is from being monetized by this vast modern network of billion-dollar industries that basically are all dependent on the simple idea that more data means more value. And of course it's true, because more data means more industries that can collect it and manage it and parse it and make inferences about it and package it and lose it, which creates jobs and money. There's all kinds of industries, especially in data collection and data brokerage. They may not call themselves that, but the ecosystem is vast and largely not something that most people see or understand exists, particularly when it comes to their mobile phones. One of the issues that we've been working on a lot is mobile devices, because so many people fail to recognize that a mobile phone is really a small tracking device, one that is such a personal product that we often forget that it's not personal at all. And in fact, so much of your information these days, and many, many companies are focusing just on mobile because it's so ubiquitous now. Much of the information that is on the phone, including your texts and your phone calls and all that other stuff, your locations, is something that's being collected about you on a minute-by-minute basis, if not faster. So what I was thinking about is really, what is the value? Where is this value coming from? Is it that companies, it's creating this industry? Yes. I think also, people would tell you that advertising and marketing of health data is a big moneymaker. And it's true that companies make more money by targeting advertising to you rather than not targeting it to you. And they can do this by reading your social media accounts, learning about your medical history, and delivering more precise individual products to you. But to some extent, much of that value depends on accuracy. And having worked in the advertising marketing industry, I can tell you that a lot of it is based on sort of supposition and guesses on what you might like and what you might buy. And now, when you think about your health data or things that are sort of biometric, like a picture, I'm sure none of us has ever posted a picture that was very, very flattering, as opposed to not so flattering, that maybe made you look about 10 years younger than you are. I've never done that. Or you may have change something a little bit on your insurance form. You may have sort of clicked an ad for something you never intended to buy. So there's some limit to that value, right? There's advertising, but there are limits there. And I think the real irony of this is that our profiles now, this detailed information about us, are almost viewed as more truthful than our real lives, per se. So decisions about whether you can get a job, how much insurance you should pay, whether you can get health insurance, are dependent a lot on these profiles versus what you report. So which is more valuable? Which is more true? I think another reason that health data is valuable has a lot more to do with saving time than anything else. And what I mean is, it saves time maybe for consumers, but for the most part, it saves time for companies. The ability of computers to effectively process, transfer, and store terabytes of data has amplified the value of health data, simply because it saves our healthcare providers, our healthcare facilities, our insurance and other healthcare services companies time. And time equals money. It makes the path to more faster and more efficient. Now, the sheer magnitude of health data being collected, shared, and stored makes the data a giant target for the place where it is probably the most profitable, and that is in the criminal marketplace. For criminals, it's not as important whether the data is accurate, because they can rely on phishing emails, they can do large-scale attacks, scams, and they're guaranteed to get some participation. Not only that, they can sell packaged data information and sell it on the black market to another place that, for example, wants the social security numbers to marry it to other data that they already have. Medical identity theft is not something that you hear a lot about. And in fact, whenever somebody asks me, and as a consumer advocate, I get asked this all the time, but what's the harm? And medical identity theft is your answer if someone asks you that, because it's a huge problem. Not only is it a problem for people in the fact that they have very little recourse when it happens and they end up paying a lot of money to deal with it, but it also can result in medical records that have misinformation, fictitious diagnoses, different things that have happened when someone has stolen their medical identity, and this plagues them for years. Not only their medical files, but their financial files also. Data breaches, of course, is another one that we talk about a lot, but the thing about data breaches is a person is 4 times more likely to be a victim of identity theft if their data is involved in a data breach, sort of the other side of data breach. It freaks us all out, but this is the reality of what the harm is there.
Michelle,
one of the harms.
Like one more minute?
Gosh, I thought I was not even talking that long, sorry. I should practice probably. So the key thing, okay, here's the key thing that I want to talk about. Consumer action focuses on underserved communities, right? So we talk about communities that are vulnerable, and that includes youth, adolescents, minorities, and people in low to moderate income groups. They are in particular targets because, for one thing, they're the fastest and growing users of mobile phones, which is where most of the data is being taken now. But they are also disproportionately facing harms such as pricing disparity. Natasha mentioned that briefly. It's been studied, and it's a true discriminatory issue where studies have shown if you're targeted as being poor, unemployed, or a minority, you'll receive higher prices for things like drugs and healthcare products. And as I said, teens and children becoming key data targets is another huge issue. If you can grab a consumer early, you can make them a customer sooner. Now, the last point I want to make is just basically that consumers, from our perspective, and we have a national hotline where we hear a fair amount about mobile more and more, they're losing trust in some basic protections, and with good reason. When it comes to healthcare, the trust is crucial, obviously, between the adoption and the rejection of new technology. And I want to make the point that trust is really the underpinning fuel for innovation. I think some people forget that, in fact, trust is what makes these products work. And so without it built in, as Peter Hustings brought up, without privacy design in the very beginning, and a concentrated effort by the government and industry to educate people about what their privacy protections really are, and not just send them these long legalese notices, would go a long way to help fuel that trust.
Thank you, Michelle. And next we're going to have Cora, who's going to talk about the possible protections, and then we'll have Ranieri.
Okay, thank you very much for having me here today. I'm Cora Hahn. I am with the Federal Trade Commission. And before I start, I'd just like to give a quick disclaimer. The views that I'm going to express today are only those of my own. They don't represent the views of the Commission or any of the commissioners. So with that out of the way, we really have seen an evolution and really a boom of activity in the health space outside of the traditional provider setting. And this ranges from websites that offer health information where people can share experiences and get advice, to mobile apps that allow people to monitor their vital signs and develop workout programs, to many sensors and wearable fitness devices given the improvement in sensor capability. To telemedicine, which can allow people to use some of these tools when it is difficult for them to actually get to the traditional provider setting. And these things really do provide benefits to consumers in many ways that my panelists have already mentioned. But as has already been mentioned as well, they do raise some significant privacy and security concerns. There is ever more information that is being gathered. And there are ever more participants in the ecosystem who have access to this information or who this information may be disclosed to. And so this is an area that the FTC is focused on in both its enforcement and policy work. As many of you know, our core enforcement statute is Section 5, which prohibits unfair or deceptive acts or practices in or affecting commerce. So deception is a material representation or omission that is likely to mislead consumers acting reasonably under the circumstances. And unfairness involves an act or practice that causes or is likely to cause substantial harm to consumers that is not reasonably avoidable and that is not outweighed by countervailing benefits to competition or to consumers. So it's a tremendously flexible statute that really applies across a wide variety of industries and in a wide variety of contexts, including the health context. And for example, one of our recent settlements was against CBR, which is a leading cord blood bank. And that case arose out of a breach that occurred where unencrypted laptop backup tapes, USB drive, were stolen out of the back of an employee vehicle. And the investigation revealed faulty data security practices, and the resulting order from that case required the company, as many of our orders do in the data security context, to implement a comprehensive data security program and to submit to external audits every other year. So turning quickly to the policy front, many of you are familiar with our privacy report issued in 2012, which provides best practices in light of emerging technologies. And there are really three basic principles from that report, which I think are particularly applicable to many contexts, including the health context. The first is this idea of privacy by design, which is the concept that companies should really bake in privacy at every stage of the development and implementation of their products and services and throughout their organization. And some of these things include good data security practices. So thinking about what information you collect, not collecting more than you need, having sound data retention and disposal policies. So for example, when you say that you're going to dispose of information, actually do it and don't keep information for longer than you need. It also includes things like promoting data accuracy on the front end. I know that's been mentioned, and that really is, I think, an important part of considering privacy throughout every stage of the development of your products and services. And it also includes constantly updating and considering. And in a time and in a space where the evolution is so quick and technology is moving so fast and there are new products constantly coming out, I think it's worth emphasizing this one a little bit. It is not enough just to sort of think about it once and then think you are done. As your industry changes, as your products change, as your company changes, companies should, as a best practice, constantly reevaluate what the risks are that they face and what protections they have in place. The second tenet of our policy privacy report is simplified choice. And this is the idea that choice should be simplified and aligned with reasonable consumer expectations. So if you are doing something with your consumers' information that they might not be expecting that you would do, you should give them notice and obtain their consent. And particularly when you are dealing with a sensitive type of information, which health information often is because of the potential for embarrassment and other significant harms, you really do need to make sure that you are getting your consumers' consent. So, and then the final prong of our privacy report is greater transparency. And this really goes to the idea that privacy policies should really be shorter and more simple and really able for consumers to understand. I think we have all seen the privacy policy that no one could possibly really read and comprehend in a reasonable amount of time. And so when companies are designing products and services and thinking about their disclosures, they should really think about making them short and clear and as transparent as possible about what their practices are. So I don't want to talk too much more at this stage, but I would like to say that our website, ftc.gov, is a tremendous source of resources on this issue, including things like, with regard to medical identity theft, tips for providers and consumers, general data security and privacy guidance, and also for mobile app developers, some guidance about what to think about as you are developing your app.
Thank you, Cora. And now Dr. Ranieri Guerra is going to talk to us about the European perspective on health data outside of healthcare.
Thank you very much for inviting me, and thank you to you all for listening to us. It's going to be rather Italian and member states of the European Union rather than European, as I guess I'm not entitled to talk about the European perspective by and large. We have colleagues from the European delegation who are much more fluent with what the European Union is trying to do, apart from being the sum of all bureaucracies of individual member states, but that's another issue. From my perspective, I've been fighting in my previous life systematically with the national authority that oversees privacy, and on the other side with healthcare providers claiming that they do not want to disclose individual patient data because of privacy and because of the individual patient-provider relationship that prevents the dissemination of sensible information or information by and large. Based on that, what I did was to design a comprehensive system that was piloted in Venice, that you all know. Venice because it's a kind of closed environment where we could really pilot any kind of potential solution to interact and integrate across the systems all information, rather than health information per se. We have a system by which, with a unique kind of number, all individuals are caught by the system. In this respect, what we have is an incredibly large database of 325,000 residents in the city that we can data mine. Basically, we can get into, and we can draw any kind of analytical work. Obviously, this entails a lot of public health interest from one side, not at the cost of individual privacy. The kind of use of this database is basically around three main areas. One is the kind of equalizing function that the governance has. The local health authority in my country is the governing body for the area that we, in a way, talk about. In the case of Venice, we have one local health authority that manages hospital care, home-based care, primary health care at a different level. This authority has a basic role of equalizing access, making access viable and equal to all the residents. One of the major issues we have in the country is, in fact, the attempt to overcome disparities, as we feel that disparity is the real problem for any kind of health system, and not only. And as it was clearly shown also by the recent report of the Agency for Healthcare Research Quality in this country. I think 2 weeks ago there was a national report that was published where inequalities in the system were in fact identified as the major problem. And the major problem also because current information system fails to identify those who are marginal to the system, those who are neglected, those who are most vulnerable and at risk. In this case, we can actually identify those people based on different indicators that we can derive from the database and try to break the usually passive, traditionally passive role of the health system in trying to find out and to reach out these people before they get sick or before they get incurable, providing different systems of care. And as a matter of fact, as Italy has the fastest aging population worldwide, we have overcome Japan quite recently. The transition between acute cure to chronic care and assistance is something that, in fact, is crucial to the system and which we can manage appropriately given the database I was referring to. Third, service management and cost containment. I guess that probably the main driver for building health information system, which is of public interest, is in fact cost containment, at least in my system. We work at a range which is between 6.5 to 8.5 of the GDP, which is spent on health and treatment. That includes acute care, chronic care, intermediate care, and is definitely almost 1/3 of what this country is currently investing in the same kind of service delivery. The implications for the cost containment objective are quite strong, and that has the definite risk of breaking privacy, because we get down to the individual patient and the individual provider. We can map individual encounters, and at the end of the day, I can tell you what the provider prescribed, for what reasons, from what company, for what kind of patients, and I can map this back since before birth to after death of the individual patients. And of course, you can understand that there is a public interest in this, but there may be an individual risk of being exposed unnecessarily, not only for the patient, but also for the individual provider. What else can I say on this? We use extensively data for different reasons than health, such as building risk models and an alert system which has been used recently due to heat waves in the country. Summer in Italy and in Venice in particular can be really hot. We had an outbreak that we shared with France mainly some 6 years back, where we estimated that anything between 6,000 to 20,000 elderly died earlier than due because of the heat wave. The alert system that allows us to break confidentiality and to being in touch with individual patient is, in fact, whenever heat alarm is emanated by the civil protection, that allows us to being in touch with all people basically who are 65 and above, alerting them and giving them suggestions or recommendations on what to do.
Dr. Guerra, sorry, one more minute, if that's okay.
One more thing.
Good.
This allows us also to promote something which is rather unusual in any given health system, which is health literacy for individuals. Health literacy, we feel, is the major advantage for an informed system that allows individuals rather than patients to become acquainted with their rights, with the possibilities of the system, with the kind of resources which can be accessed, and how these resources can be accessed. In a way, this leads us not really to evidence-based medicine, but to something which is a step forward, which is evidence-based policy formulation that the government and the public sector has the responsibility to develop in order to be as effective and impacting as possible on the health profile of residents.
Thank you very much.
Thank you.
And now, Doc Searls.
Thank you. We have had privacy normalized in civilization for 10,000 years. The clothing we're wearing has privacy by design. The whole entire garment industry has had privacy by design, and it's been well understood for a very long time. The internet is 18 years old. It's still a kid. It's still learning to drive. It isn't old enough to, it's barely old enough to vote. We're prototyping absolutely everything that we're doing here. Companies that we consider bulwarks of the way things are done on the internet, Google and Facebook and Twitter and so forth, weren't around when the internet was formed and are incredibly young and actually very underdeveloped as companies go. They are also infrastructural to a degree that's almost impossible to comprehend. If you have it's kind of interesting to think about this. If you're operating in something as infrastructural as, say, a nuclear power plant or a dam, there are people in government that can come out and inspect what you're doing. Nothing like that is happening at Google or Facebook. Even the people in there don't understand the scale of what they're doing right now. But I also think it's also very temporary. It's, again, all being prototyped all the time. We have to still work out what privacy is in the cyberspace that we share. And that space was created not by the phone and cable companies that we pay monthly bills to. It was created by a bunch of geeks that met in high school and worked together in college and went to work for defense departments and places like that and came up with protocols. And protocols are nothing more than manners. And the protocol that is the base protocol for the internet is a set of manners called TCP/IP that basically say nothing more than we'll make the best effort to get packets from one end of this thing to the other. And the ends are nodes. They're individuals in most cases. Each of us is an end on the internet. Each of us is legitimate as an end on the internet as any of the giant companies that we're used to dealing with. And if you think of a marketplace in the original sense is basically a table for two. And in fact, one of the things that motivated us to write the Clue Train Manifesto in 1999 was a line from a geek who said, don't think of the internet as a bunch of billboards next to the information superhighway, but rather as a table for two, because that was how it was designed. Now, if you look at your role as a customer or as a consumer, and there's a difference in the marketplace, the one common thing we always have is us as individuals. We are the one legitimate place where data should be integrated and carried from one place to another. We are the one entity that has an interest in how it's used. So I see us individually as the pivot points between all of the healthcare data that we can gather and how we use it elsewhere in the world. It's interesting, having spent 25 years of my life in Silicon Valley, to watch the same mistakes being made over and over again. And here's the biggest one. We are going to silo our data because it has more value to us as an asset than it does to our customers and our users and the rest of it. And that has been proven wrong over and over and over and over again by every possible interpretation of laws of positive externalities in economics, and yet we continue doing that. And the quantified self movement is a really good demonstration of that. My Moves app that tells me how many steps I took today, like it tells David, I suppose, he has a similar app. The Fitbit thing, my Withing scale, even if they have the data open, it's not really in a form where I can integrate it. I have to go to their website. I have to do complicated things in order to integrate this. But we are legitimately the points of integration for our own data and the points of origination for what gets done with it. And that is a fundamental problem that we're going to need to solve, and we cannot solve it on the system side. Systems always want scale. This is what we make when we make software. It's what we make when we make hardware. We want to get scale. The problem with scale is we want to normalize everything we're scaling to. So we want to treat our patients, we want to treat populations as templates. None of us is a template. I look out here in the audience, every one of us is very, very different. That's what makes us human. That's what makes us wear different clothes from everybody else, right? We are profoundly individual. This is a conundrum for everybody developing a system, and the only way to solve it is on the individual side by developing tools and services that work fundamentally for the individual, or in the case of healthcare, for the patient. So I'm trying to be as short as I can here. Something that when we look outside of any particular business like healthcare, as we're trying to do here, is we're always looking to see what the sale value of things are. An interesting irony of data is it has far more use value than sale value. And in fact, the value to us of everything that we have on our hard drives has enormous use value and very little sale value for us. But there's a lot of talk lately about, geez, Google's making a lot of money off of my data. Why shouldn't I make some of that money too? I think it's the wrong angle to take, and I think it's kind of a dead end if anybody goes down it. I mentioned earlier that consumers and customers are different. I worked for years in broadcasting, and commercial broadcasting especially, has this fundamental problem, which is, and it always had this, which is that its consumers and its customers are different populations. They sell their consumers to their customers who are advertisers. Google and Facebook have exactly the same problem. It is an existential problem, and it is going to give them trouble in the long run because they are absolutely addicted to the advertising marketplace, and they are allergic to having direct services, paid services to customers that are you and me, and they're not going to go there, and they're busy. And Facebook thinks we're competing with Google. Google thinks we're competing with Facebook. We both were competing in the advertising business. All of us on the receiving end of this may have noticed that as big as data gets, that advertising isn't getting any better. In fact, it's getting worse. On Facebook, where I have 9,000 friends and all kinds of things in my timeline, they know I've been married for 20-some years. I get ads every day for under 30 singles. How accurate is that, right? How bad are the manners of that company to imagine that I would want to see that they would sell that kind of advertising? Well, they're doing it because they don't have a relationship with me. They can make billions tomorrow if they sold services to me. They could be of enormous help to the healthcare industry if they actually made customers of their consumers, but instead they're consumers of the product being sold. So an interesting development, I think, is going to happen. We had, with personal computing, an irony of extreme proportions, of an oxymoron. Computing in the beginning was not personal. Thomas Watson famously said, I think there'll be 5 computers in the world. There was a piece in Popular Mechanics in the 50s that said, I think, this one guy wrote, I don't think we're going to see any computers over 2 tons in the future. What's happened is that in a series of moves, we as individuals have taken and personalized something that was entirely corporate. We did it with computing. We did it with networking. If you came along in 1995 and said, you're going to let people use the internet in your company, they'd say, no, we have Novell, we have 3Com, we have networks that we buy, we go to the phone company. Well, the internet gave us all powers that were unimaginable for corporations. We can communicate freely all over the world. We're going to do the same thing with big data. We're going to do the same thing with the cloud. The cloud is a term that's been used entirely for big data. You put stuff in the cloud out there. If you listen in the business, they talk about the cloud all the time. We are all going to have our own clouds. And those clouds are going to have all of our healthcare data, and we're going to be the ones managing it, and there's going to be a business in helping us do that. So I'd just like to leave you with that thought. Just in the last few months, the term personal cloud has come up as not just as a term, but a bunch of geeks have gotten together to work on solutions based on that. And that's just a really fun thing that I've been following. So if we have time or interest, we can talk about that.
All right. Thank you very much, everybody. So we heard a lot about the enormous potential value of health data outside of healthcare, both on the system-wide level and on the individual empowerment level. But as a journalist, I'm kind of a glass half empty kind of reporter. And so I want to talk a little bit more about what the potential concerns are. And as I was preparing to come here, I went and I looked at the top dozen health information sites on the web. And I use this program called Ghostery that identifies for you what third-party entities are collecting information on you. And so on Everyday Health, which is one of the top 5 sites, there were 25 third parties, data brokers, advertising networks, Facebook, Twitter, that collect information about what you do. And some of the things you can do on Everyday Health are look up bipolar symptoms, depression symptoms, cancer symptoms. And although they say that it's not personal information because they may not have your name, you're given a unique identifier by which these companies can follow you around. And it's been shown that it is possible to re-identify people. So it's at best pseudonymous. And then I went to something called the Network Advertising Initiative, which is a self-regulatory body for third parties operating on the web that do behavioral advertising, which is advertising that's based on following you to multiple websites and showing you ads that are tailored to what you might be interested in or what they infer you're interested in. And so they have a new policy for 2013 about sensitive data, and health, at least parts of health, fall into this category of sensitive data. And so what they say is it's difficult to draw bright lines between sensitive and non-sensitive data in the health space. But they've tried, and what they said is certain kinds of health data require opt-in consent. So these are all types of cancer, mental health-related conditions, and sexually transmitted diseases are precise health conditions and require opt-in consent. Now, of course, it's voluntary to belong to this self-regulatory group, and when I went to all these health sites and looked at cancer and mental health, nobody asked for my opt-in consent. The other part is other conditions such as acne, high blood pressure, heartburn, cold, flu, cholesterol, exercise, diet, vitamins, and supplements, they don't consider to be health, and they don't require consent. And then the interesting thing is that the consent that you're being asked to give is the consent to be shown behavioral advertising. You're not consenting about whether you want data about your sexually transmitted disease, your cancer, or your mental health related conditions collected. They're collecting it anyway. They're only going to ask you whether you want to have an ad delivered to you about it. So one of my questions for the panel is, how do we feel about that? And what are our concerns about that? I did a story a couple of weeks ago about somebody who was profiled as a multiple sclerosis patient, and she received a flyer in her house inviting her, like addressed to her by name and address, inviting her to some MS event sponsored by Pfizer and another drug company to learn about, how to manage their symptoms and what medications are available. And she had no idea how she got this thing, because she's very careful. She doesn't give out her email to stores. She doesn't have MS. She did go online and look up a lot of health conditions last year. And I decided it'd be a good story to try to find out who had mistakenly profiled her. So first I called the drug company, and they said, oh, she's not in our database. We have a voluntary patient opt-in database for people who do have MS and who do want to participate. And then finally I got to the top of the drug company hierarchy, and I was told that they had bought her name, address, and multiple sclerosis condition from a third party. So then I went to the third party marketer, and they said, oh, they had bought it from a survey company, because this person had taken a survey, and in the survey she identified herself as a multiple sclerosis patient and agreed that she wanted to be available and gave her name and address. But they wouldn't give me the name of the survey company. So in fact, the person who was the subject of all this doesn't believe she ever took a survey, and certainly would never have given her name and address and identified herself as having a disease she doesn't have. So that goes back to the other points we discussed about incorrect data. And for me, what's problematic here is you can't get to the source to correct it because you have no rights to see the information. And the question is, are there potential downstream consequences, like, if you are later on denied something or you got charged a higher price for something, you're never going to know why. And so the lack of transparency, I guess, is something I was going to ask you all to talk about. And then the third thing was, as I was noodling around online, I found this company called Gravity, for which I have a slide. Cat. So this is a company in the UK that's a consultancy. They do not do online analytics where they anonymously track you, but they work with companies to segment their consumers and figure out how they think about different products. And so these are consumers segmented into categories like striving survivor, resentful victim, it won't happen to me, denial, overwhelmed, and I'm just going to read you a couple of the descriptions of these. So if you're segmented as a denier, negative and reactive about health, can get aggressive when doctors suggest they have a cholesterol problem, feel they have better things to worry about. Then there's resentful victims. Take high cholesterol personally. It's not fair. It makes them feel that their best years are over. They'd rather not think about it. Then there's concerned partner, which are organized people who take high cholesterol seriously and follow doctors' advice. Then there's just in case, fairly optimistic, don't worry about health, but like to feel they're doing the right thing. And so I guess when I think about, when I'm asked what's the harm, really it's all benign, I worry, and this is a hypothetical, right, because they interviewed people who volunteered to be interviewed, but I do worry about what segments people are getting put into without their knowledge or consent, and what the potential downstream consequences are. So that's what I wanted to ask you. What are your concerns about this, and what do you worry might be the potential downstream consequences?
I feel like I should speak here because you basically described my job too. I didn't know they would be so similar. The lack of transparency and the lack of the ability for consumers to correct and delete their information is a huge problem, because this information sticks around. And I think I mentioned this briefly in my comments earlier, that it's ironic, I think that's the correct word to describe, that your online life is viewed as almost more truthful than your actual life. And it's been proven that employers, potential employers, banks, insurance companies actually peruse different sites and buy information from data brokers about you to determine whatever it is, whether you'd be a good employee, whether your rate should be this high or this high, whether you're a good credit risk. And of course, one of the biggest financial harms that occurs is the credit score. And there have been studies that shown just how often credit scores have erroneous information and just how bad that can affect your future, clearly. like I said, I think this disproportionately affects underserved communities, and of course a large part of that is to do with mobile phones. If you're more likely to have a mobile phone, well then you're doing more things on your phone, and that includes banking and financial and other sensitive things. I think it's a bunch of baloney. You know, the NIA self-regulatory process, of course they're trying, but what they've done is define things for you. And they know very well that the way they've defined sensitive information is clearly lacking, and the way that they've sort of parceled out different medical diagnoses is pretty ridiculous. And if anybody uses their common sense and applies it to a lot of these different initiatives, it's clearly wrong, and it clearly makes no sense. And I think most consumers, when they get a look at those, are pretty turned off. I've been doing work with the NTIA. People have referenced this White House report, which actually bore this process through the Department of Commerce, which is developing voluntary codes of conduct for industry around different online privacy issues. The first one that we've tackled is transparency. So I can speak a little bit about what you learn from industries, and that is very little. They either, I'd like to say that they are obscuring, and I think in many, many cases this is true. Getting information out of these companies was incredibly difficult. This was a public process. Anybody can watch it. The White House has some hopes pinned on it, as do advocates and others. But it has taken a year to come up with a notice that tells consumers on their mobile device what information is being collected and to whom it's being shared. Now, the advocates and industry have worked together to come up with what we think is most important to you. But that's very difficult to do when you don't get all the information and you don't learn just how much information is being collected and how often. I've had some sort of candid conversations with developers, many of whom are from the open source industry and are very pro-privacy and do not like seeing what they're seeing. Of course, they have a lot of pressure to get a product out. But they have candidly told me just how invasive it can be, that people, the companies anybody can see records about your, I want to look at what this customer or consumer did for the last week, and can really learn so much about where you've been, who you're speaking to, who you're meeting when you go there, what you're telling your boss via email, what you're posting on Facebook, et cetera, et cetera. And so I think what people don't really quite get is that many of the services in this industry are to marry unidentified data with identified data. So you take online, per se, data and marry it together with the tons of offline data that's available about you publicly, and then you have a complete picture, at least in terms of what these companies think and decide and make inferences about for you.
Thank you. Anyone else wants to?
All right. Let's also take a different perspective on this from the user viewpoint. We have two different areas here. One is criminal activity, which is clearly defined and for which we have cybercrime and cyber police. So that's an area where we have little to do rather than enforcing police activity and trying to be as systematic and pervasive as possible. The second area is the area of ambiguity, whereas, as my colleagues have addressed, there is a way by which the industry can, in a way, persuade individual clients or potential clients to buy in without really understanding what the implications are. In this case, the irony to me is that technology and technological progress in the web and in the information industry has not been coupled by a kind of similar improvement in the educational system. If you think about that, there is no real instruction, no real education, no real skills which are taught at school since the beginning. Our children have been growing in this incredibly pervasive environment, whereas data and information are just there. But no one is really educating them on the kind of use they can use, on the kind of protection, self-protection they can adopt, on the kind of measures, on the kind of consent that has to be given and the way it has to be supported by knowledge, by understanding, by skills.
Thank you. I'm going to open it up to questions, unless you, Doc, did you want to make a comment?
Just a short one, which is that in the course of a day, I belong to every one of those categories up there. And I'm sure that's probably true for most people here.
Right.
And another thing is that there's an interesting question around harms, is that it's actually comical how lousy they are at what they do with all the data that's collected. And it's because we're not giving our consent. It's because we have no control over this. So all the channels you go down as a reporter and that we're looking at here, what we find is that, I mean, the idea of following us around, almost always what you're trying to do is sell us something. And we're not buying something most of the time. Most of the time we're just living. And a lot of the time we're not that predictable, and that's what makes us human. So we got to turn this thing around.
And let me just say just very quickly that transparency is a very significant issue. So, companies should, I think, really, when they're designing their products, be very honest and upfront with consumers about what they're doing with their information, who they're transferring it to, and then consumers can make an informed choice.
All right. So are there questions?
Hi, my name is Albert Dunne. I'm a consulting toxicologist, and I'm so glad to hear this broad perspective of both the benefits and the risks of data outside the health system. And I want to address Dr. Searls' point specifically. I'm here to promote the concept of a consumer-managed and led organization in which the individual personal silos of data, such as we might store at Microsoft Health Vault, could be shared at a meta level, mined recursively for our benefit in terms of tracking our medical conditions with cohorts of our age and gender and so on, but also give us the opportunity as a society to sell our anonymized data, and we would reap the benefits of the sales, whether it was for advertising, mining, marketing, and unlike the data sets sold now, which don't allow the purchaser to touch back to the individuals for our privacy protection, in this society where the data are born free, they've never been identified, we don't know who you are, we can offer companies the opportunity to touch back to people with information about a drug or a device that they would actually care about, unlike you not caring about 30-year-old dating services. Dating services for 30-year-olds. If you had diabetes, you might be interested in information about a diabetes drug or device. If it was able to come to you without the company identifying you personally, but through a firewall behind which you're simply a number to us.
And do you have a question?
What do you all think of that idea? Have you considered it, where the patients would sell that data and manage it themselves?
I said something about that earlier, and I'm sure you got it. I think for the most part our data has more use value than sale value. I'm not excluding the possibility that sale value is there. The thing is that I think if we focus entirely on that, once again, we're just still in that marketing. We're still part of the marketing mill. And we are overwhelmed right now, just absolutely overwhelmed with marketing BS just coming at us all the time. If you can get wheat instead of chaff and make it clear that what you're getting is wheat and not chaff, that's great. But I think the risk is that there are any number of things right now. Every marketer in the world thinks they're giving you exactly what you need right now. The only thing missing is your actual conscious consent for that. But if you can separate that out, that'd be great.
All right, thanks. We'll take a question from your questioners. Please keep your questions short.
As a practicing physician who sits with patients face to face, I'd like to kind of put you in my position for a moment and see how you would respond to this. One is the issue of the fact that we are not at this time asking patients if they want to opt in or opt out of the EHR and the HIMSS and the other connections that may be behind that EHR. How can we in good conscience do that? That's question number one, the issue of opt-out, how we deal with that. And the second question that relates to that is, if indeed we believe that privacy is synonymous with patient control, in order to give consent, informed consent, there needs to be a discussion about risks and benefits. Given that we have often overestimated the benefits of our current reality of health IT, and we often underestimate the risks, could you speak to that discussion that
Okay, well, I can start off. I think, as a provider, if you're having that conversation, there's information that is, I think, disclosed in the traditional provider context, which, whether it be, as it used to be in paper or now in EHRs, is one sort of transmission. I think, talking to patients about if they want to, outside of that context, offer up their information to other third parties, I think it's important to let them know that information, could potentially be disclosed to other third parties, and just be aware of those risks. At the same time, you might, as a provider, have a good sense of what particular resources might be useful for this patient outside of that traditional context, and those can, I think, indeed provide benefits. So those are some of the things I think I would consider.
I would just say briefly, too, that if you are having those conversations, bravo, because I think that almost never happens. Most of the time people go into a doctor's office and they get these papers and they're told to sign them, when in fact they don't need to sign them. They're not required to sign them to get care. But there's a real disconnect, not just from the patient's perspective, but from the doctor's offices, the healthcare provider perspective, and the people who deliver these forms may not. So maybe the first conversation would be with your staff or with the people in the office to make sure that everybody understands the privacy implications and the risks, so that that can be explained. One of the things that we've done at Consumer Action is we do educational materials, but this time we took some changes in California law and different patient privacy laws. There are many in California, and narrowed it down into a wallet card, because we were asking ourselves the same question. How can we sort of arm people with what they need, and in terms of not just the information, but what questions to ask? So I think it's two-part. I think, consumer groups can help do that, but maybe help your patient understand what questions to ask too. They may not be able to understand the difference between authorization and consent, and how those two might create a different divergent path. So I think going through those key things, going through the exceptions and the loopholes, it would be a pretty long conversation. not anybody's fault except, the government's. But I think that would be crucial. And also, from our perspective, making sure that you have that conversation available in different languages, because so many people who are even more at risk for some of these privacy harms English is not their first language.
What do we do after we have the discussion and they say, I don't want my information in a digital format?
Well, I think as a healthcare provider, it's sort of your decision there to either help them know where they can go or what services they can get from you, if there are any available, or like Cora mentioned, are there other places where they can get care, and also to open yourself and your practice to the option of those types of patients who may want to pay in cash or whatever, to make that as thriving a part of your practice as the other part.
We'll take a question from here.
Hi, good morning. I'm Steve Davis. I'm a psychiatrist. I chair the American Psychiatric Association's Committee on Electronic Health Records. One of the things that frequently comes up is the issue about mental health and substance abuse information, and how that is oftentimes viewed as more sensitive than other health information. However, that sort of contributes to the stigma about mental health conditions. It used to be years ago that epilepsy was a sensitive health condition that people would not really talk about. Cancer used to be one of those. And over time, those things lose that stigma. Mm-hmm. And so one of the concerns I have is that, on the one hand, I think all health information should be treated as sensitive. But if we're going to compartmentalize into less sensitive and more sensitive, does that enshrine mental health conditions to forever have this kind of stigma about requiring this kind of extra secrecy and so forth?
Does anybody want to respond?
The issue is also who is the custodian, in a way. So assuming that a mental health patient is in need of a custodian, is in need of family network, for instance, supporting for whatever reasons, including seeking care, including accessing care, I guess that the main problem is to whom this data set can be open, and who can be allowed access and decision-making for the patient or on behalf of the patient. I guess that the issue of confidentiality is no worse or no better than any other clinical information. I mean, to me, to make a difference, if I would be a cancer patient or mental patient or diabetes patient or whatever, it doesn't make any difference. Data are mine, and I want to keep them mine as much as possible. In a mental condition, if I'm not self-sufficient, if I can't make decisions on my own, I can identify my custodian, and my custodian can be associated in a way. That's at least in our system.
And there are technology solutions that offer that. Deb Pio could probably go through all of them with you. I can't do that, but I know that they exist. So I think that's important right from the start, the whole privacy by design thing. And it's funny because when you were saying that, I was thinking probably to an insurance company, or just from a financial standpoint, obesity is another one that would be considered sensitive, and in terms of impact on someone's life from being exposed, could be even more of a sort of stigma. But I would say that a way to look for is the technology solutions that create the scenario that he was describing.
Okay, we'll take one more question.
I'm from Oregon, and I hope that separating the wheat and chaff is not genetically modified. That said, I have a question. I am going to be meeting with my senator, Senator Wyden, who, is the legislative assistant senator on this week, and he's very interested in updating internet privacy laws in general. So one question would be, can we do it well through the regulatory process, or is this the move that we need to do through federal laws, especially in regards to fair information practices? And secondly, my second question is, I jokingly was thinking, is there the equivalent of credit scores in regards to identity? And I found that, in fact, there is something called identity scores, and one of the things that makes it worse is data breaches. So I'm wondering if you know anything about that, and who's collecting that information and what they're doing with it.
I could take the first question, perhaps. I think obviously there's need for legislative or regulatory action here, and has been for a long time. In Silicon Valley, we tend to worry about that because we think any new law will protect yesterday from last Thursday. But we've got here problems that are very long-standing. I think what we also need are things we can do on the user side that are outside, that are within the scope of plain old freedom of contract that got forgotten when industry won the Industrial Revolution, and our rights to freely form contract were ignored. And we're especially forgotten on the internet, where one of the developers I know has a wonderful history of e-commerce where he says 1995, invention of the cookie, the end. We've sort of stopped at that stage. When we go to a website, we're not actually going anywhere. We're just sending a request for a file. And we're getting much more than that file. We're getting far more than we consented to have. I think one of the things we can do is something that a new organization I'm part of called Customer Commons is doing as a client of the Cyber Law Clinic at the Berkman Center at Harvard Law School, where I've been active for the last 6 years or so, where we are working on terms that we can assert. Very simple, easily understood ones that can be understood by machines and by lawyers as well as ordinary people, that say things not just like, don't track me, but here are my policies. And you have to acknowledge that you've heard my policies. And if you don't acknowledge that, there may be consequences. The dialogue that happens between us and providers of all kinds are ones that should be completely even. And right now, the normative assumption is that we are always the client and they are always the server. But the way the net was designed, we don't have to be the client and they don't have to be the server. We're both peers on a network where there can be common understandings. And if we get somewhere with these new terms and conditions and policies, I think it'll be very good for business as well, because we'll have that consent, we'll have real understanding, and not just the assumption that it's okay to track us around as if we were animals or so, or criminals or whatever.
All right. Thank you, everybody.
Can I say one thing on this?
Yes.
As you may know, Italians have a passion for laws. We have over 100,000 regulations regulating everything, every single breath, and the government is very pervasive in this case, with the exception of the internet. Cyberspace is in a way almost totally unregulated. We tried systematically to identify ways and means to keep the whole thing under control, and we gave up. It's just impossible. What really matters to us is to try to develop a protocol by which websites and providers can be certified and can be accredited, and the way the services they provide can be monitored by a national authority, by public authority, by which consumers, users, those who access the internet can rely on kind of public seal of quality and whatever. Otherwise, it's just impossible. Our own experience is that we can't really regulate extensively.
I just want to say that self-regulation has failed. I think that's pretty clear to most people. Maybe some industry people are still holding out. But the White House needs to issue a baseline privacy legislation, and I think that's where the conversation will really get started in our country.
All right. Thank you, everybody, for participating. Thank you. Thank you. Thank you.